the nurses ignoring your call bell isn't always about being short-staffed. Sometimes you've pressed it during one of the busiest moments of the entire shift, when critical patient handoffs can delay non-emergency requests, and most families have no idea this happens. You press the button at 7 in the morning because you need the restroom, the light clicks on, and then you watch the hallway go completely quiet for the next 45 minutes. The staff isn't just busy, they are legally locked into a mandatory operational pause that prioritizes their shift paperwork over your immediate comfort. If you want to understand how the hospital's actual operating rules work before you or someone you love ends up in a bed, hit subscribe so you aren't caught off guard by the paperwork and the pauses. We walk into a hospital expecting a continuous stream of care and a baseline of privacy. The reality is a fragmented system built on acoustic illusions, mandatory care blackouts, and physical tethers that can legally halt your pain medication. Let's walk through the 5 rules that catch almost every family off guard. The first rule you run into is the ghost doctor mandate, which means your own primary care physician is legally barred from managing your daily inpatient care. Your family spends 3 days asking the nursing staff to page your trusted doctor of 15 years, only to be told he hasn't been credentialed to round at this specific hospital system for a decade. You are entirely under the care of a hospitalist you have never met. Over 50,000 physicians in the U.S. are now certified hospitalists, and according to the Society of Hospital Medicine, they manage more than 70% of all internal medicine admissions in large hospitals. The legal chain of custody for your care shifts entirely to the hospitalist the moment you are admitted. The doctor who admits you in the emergency room is rarely the doctor who discharges you. Care is fragmented across multiple shifts, meaning you might see 3 different doctors in a 48-hour period. The hospitalist becomes the attending of record, legally responsible for the billing and the final discharge, completely sidelining your outside primary care doctor. If you have a specialized condition, like a broken hip and diabetes, the hospital activates co-management. The orthopedic surgeon handles the hip, but a hospitalist handles the diabetes. This mechanism requires daily sign-outs between these siloed teams, meaning your family has to track which specialist owns which decision on any given day. Families frequently describe the exhaustion of having to re-explain a complex medical history, baseline mobility, and medication allergies to a completely new doctor every single morning. It creates a feeling that the patient is just a case number being processed by a factory line, stripped of the continuity of a doctor who knows them. The second rule is what I call the acoustic privacy illusion, where the curtain around your bed blocks sight lines but lets every word travel across the room. The next morning, your roommate's visiting daughter cheerfully mentions to her mother that the guy in the other bed needs a new roof, offering her husband's contracting services, all because of a financial conversation you had in a whisper the night before. Approximately 60% of older U.S. hospital buildings still rely heavily on semi-private rooms due to the prohibitive costs of retrofitting to single-occupancy infrastructure. The physical design mechanism here is simple. Hospital curtains are mounted on ceiling tracks with a 12 to 18-inch gap at the top and bottom for airflow and HVAC circulation. This guarantees that sound travels freely across the track, rendering the curtain acoustically useless while satisfying the visual privacy requirement of building codes. The physical curtain provides visual privacy only, with zero legal, regulatory, or operational acoustic privacy. HIPAA regulations apply strictly to the hospital staff, not to other patients. If a roommate overhears your diagnosis, financial status, or family disputes, the hospital has no legal mechanism to penalize the roommate or prevent them from sharing that information. The hospital cannot gag your roommate, nor can they force the roommate to leave. The actual conversations overheard by a roommate are not recorded anywhere. State-level variations exist, but they are limited. California's Title 22 regulations have strict square footage and physical partition requirements for semi-private rooms that indirectly improve acoustics, whereas states like Texas rely on general facility licensing that does not specify acoustic dampening between beds. Patients and families in shared rooms report a constant, low-grade anxiety about being overheard. They describe leaning in to whisper, using vague terms for sensitive body parts or financial issues, and feeling a deep sense of violation when they catch the roommate or the roommate's visitors staring at them during a vulnerable moment. The third rule is the shift change lockdown, a mandatory 30-minute operational pause where the unit intentionally delays non-critical care. At 6:55 a.m., you ring the call bell because you need a bedpan. The light turns on, but no one comes. You ring it again at 7:25. A nurse finally enters at 7:40, apologizing and explaining they were in the middle of a mandatory bedside shift report and the unit was in a care pause. Nursing shift changes, typically at 7:00 a.m. and 7:00 p.m., trigger a mandatory unit-wide operational pause. During this 30 to 45-minute window, non-emergency care is systematically deprioritized. The charge nurse implements a care blackout protocol. Call bells are routed to a central desk but are intentionally not dispatched to rooms unless your acuity level is flagged as high risk, such as a fall risk or an active IV. Standard requests like water or positioning are queued until the handoff is complete. There is a 15 to 20% drop in call bell responsiveness during this window, with average wait times for non-urgent requests increasing by up to 12 minutes. Many hospitals now mandate bedside shift reports, where the outgoing and incoming nurses discuss your entire care plan out loud in the room. This is a required accreditation step by the Joint Commission to ensure information transfer accuracy. Because of this bedside shift report, intimate care details are broadcasted out loud in the room, regardless of who else is present. Families often misinterpret this shift change blackout as the hospital being dangerously understaffed or simply not caring. They describe walking out into the hallway at 7 a.m. and seeing an eerie quiet, with nurses huddled in the break room or at the desk, while call bells flash silently in the rooms, leading to feelings of abandonment. The internal frustration of the family during this blackout is rarely recorded on the record unless a formal grievance is filed. The informal, verbal, handoff conversations between nurses in the hallway outside the patient's room are not legally required to be documented in the electronic health record, only the final agreed-upon care plan. The fourth rule is the contraband sweep, a safety protocol that allows the hospital to confiscate your personal belongings without your consent. Hospitals possess the legal authority to conduct environmental safety rounds to identify and remove items that violate fire codes, infection control, or safety policies. Items deemed clutter, fire hazards, or infection risks are bagged and removed. A family brings in an electric heated blanket for their chronically cold mother. During the afternoon environmental safety round, a staff member confiscates it because it wasn't on the hospital's approved electrical device list. When the family asks to take it home that evening, they are directed to the main security building on the other side of the campus, which is already closed for the day. The legal authority to confiscate items without consent varies by state. In some states, fire codes grant hospitals blanket immunity to remove any item deemed a hazard. In others, patient rights statutes require the hospital to obtain the patient's or proxy's consent before removing non-hazardous personal property, though the definition of a hazard is often broadly interpreted by the hospital. During these sweeps, environmental services or nursing staff use standardized contraband bags. Items like glass perfume bottles, extension cords, or even large floral arrangements in immunocompromised units are placed in the bag, tagged with the room number, and immediately sent to the loading dock or security, bypassing the patient's bedside entirely. Confiscated items are rarely returned to the room. They are logged into hospital security, and families must navigate a bureaucratic retrieval process, often only able to collect the items after the patient is discharged. Lost, delayed, or confiscated patient belongings consistently rank in the top 5 of patient relations complaints, accounting for roughly 12% of all non-clinical grievances. When personal items are confiscated, families don't just feel inconvenienced, they feel a profound loss of comfort. A confiscated family photo, a specific type of lip balm, or a favorite sweater makes the sterile hospital room feel even more alienating. The bureaucratic runaround to get these items back adds insult to the injury of having them taken in the first place. The fifth and final rule is the wristband tether, which legally classifies your plastic ID band as a medical device that halts your treatment if it comes off. You find the plastic band itchy and remove it to take a sponge bath. 10 minutes later, you ask for your scheduled pain medication. The nurse enters, sees your bare wrist, and states she cannot give it to you. You argue you are in the right bed, but the nurse explains the scanner cannot verify your identity, and hospital policy forbids treatment without the scan. If the wristband is removed, cut off, or falls off, the legal chain of custody for the patient is broken, and all care, including pain medication, must legally halt until a new band is printed and scanned. Staff are required to scan the wristband barcode for every single intervention, including administering a simple over-the-counter painkiller. The barcode medication administration software is hard-coded to prevent workarounds. If the band is not physically present to be scanned, the electronic health record blocks the nurse from documenting the care. If a nurse tries to manually type in your name because the wristband is missing, the system requires a hard stop override, which flags the nurse's compliance record and requires a manager's password. To avoid this disciplinary flag, nurses will simply refuse to give the medication until the band is replaced. The removal of the wristband and the resulting delay in care must be documented in the electronic health record as a barrier to care or a patient refusal of identifier. Patient misidentification errors cause an estimated 100,000 adverse events annually in the U.S., according to the Institute for Safe Medication Practices. Because of this, wristband scanning compliance is directly tied to a hospital's reimbursement rates and accreditation. The quiet irony is that the very system designed to protect you from errors ends up treating your physical comfort as secondary to a barcode scan. Patients describe feeling like inventory in a warehouse when this rule is strictly enforced. The sound of the scanner beeping before a human interaction occurs makes it feel that the technology and the liability protection are more important to the staff than your immediate physical pain. This is just education on how the system operates, and any personal medical decisions about your care or comfort still belong with you and your own doctor. Next time you walk into a hospital room, check the gap above the privacy curtain and ask the nurse exactly when the next shift change blackout will hit.